A clinical example of this would be if you have a vancomycin concentration that's incredibly high or incredibly low, look at when it was drawn. I mean, I just had a patient that had with a goal vancomycin trough of 15 to 20. We had a patient whose trough was 36. Well, they drew it a little early, as in like several hours early. So when I did the math, it actually would have been a trough of around 16 or 17. And so I think we react to numbers that they must be right if something gave you that number. And so I think it's always important to evaluate what you're given.
Right. I think the other big one that happens more frequently than I think it should in the hospital is getting an elevated potassium. You can have a potassium come back at 6.3 and you're like, oh my gosh, I need to go ahead and, treat hyperkalemia. Well, you call the lab to make sure because you're like, well, none of the other lab values seem super off. Oh, the sample was hemolyzed. And so when your cell's hemolyzed, they release extra potassium. And so when you recheck the sample, then it's normal. And so you don't need to do that extra measure. So again, if you don't do it yourself, and even sometimes if you do it yourself, if it doesn't sound right, double check it.
Yeah, and along those lines, we have mix-ups in the hospital with patient samples. Mm-hmm. INR is one that, you're trying to get their INR up because we started them on warfarin and all of a sudden it suddenly jumps. And you're like, that's odd. That shouldn't have happened. I usually ask my team to get a redraw because if they just rerun that sample done in the lab, it's still labeled the same way. You're probably going to get the same result. Whereas if they redraw, we've had several instances where it's been the wrong patient. Lab mix-ups. This can happen if you're looking at a CBC and things suddenly drastically change from where they've been and the patient's been pretty stable and now all of a sudden they're severely thrombocytopenic. This doesn't make sense. Mm-hmm. So let's get a redraw. A lot of times there's been a mix-up. So don't just react to one number at one point in time. Always kind of question it if it looks off.
I think a bigger concept to remember as well is just because you can grab a level doesn't mean A, you know how to interpret it, and B, you know what to do with it when you get it. Good example of this is the 1,3-beta-D-glucan test, or the Fungitel that we use to check and see if somebody has Candida in their blood. FDA has a certain concentration level on that one to say, yes, it's a positive test, or no, it's not a positive test, or it's an indeterminate test. Well, clinical data doesn't support that. Clinical data says that the level should be significantly higher, that you need to get more than one. And so when the level comes back as, 50 or 96 or something, where it's per the FDA, greater than 80 is positive, well, 96 per the clinical literature says that it's indeterminate. And so what do you do with that? Did you actually need to draw it? And if you did need to draw it, okay, well, now you have 96, now what? Do you get another one? Do you not get another one? Do you pay attention to it? Do you not? And so I think that's really important to remember is if you're going to ask for a level of something, whether it's a drug or a lab, you better as heck know what you're going to do with that answer when you get it.